Let me begin with a first slide with a question for the postgraduates. What is the diagnosis? And since I don't want to encroach into my 15-minute presentation, this is a non-contrast CT scan. Look at the liver, and you want to compare the attenuation of the liver parenchyma with the spleen. And it's white because it's full of metal. And in addition, there are these lesions. So this is hemochromatosis complicated by hepatocellular carcinoma. And this patient, sorry? Yes, you are absolutely right. So that's the third diagnosis that the postgraduate should have picked up, that this CT scan is the other way around. And so this was actually a 65-year-old man that I looked after who had serum ferritin of 2,660, alpha-fetoprotein of 6,000. But postgraduates remember that you can get this kind of parenchymal metal overload also in glycogen storage disease, individuals who have had thorotrast, amiodarone, as well as cisplatin. All right, so iron overload is actually the cause of the most common inherited cause of cirrhosis, hereditary hemochromatosis for adults. But there is an iron overload syndrome that we heard about yesterday from Dr. Yacha's beautiful presentation, and I'm not going to really dwell on that. I want to focus on the adult or the late onset hereditary iron overload syndromes. Let's begin with the phenotype. The defect is primarily in the liver and the enterocytes, where there is increased absorption of iron, but it's a multisystemic disease, as shown here, involving the skin, the heart, the joints, as well as the pancreas, and causing hypogonadism, as depicted here. The important thing to keep in mind is that there is significant delay in diagnosis. A study was done not so long ago that looked at manifestations that the patients had experienced before the actual diagnosis was made. And so for more than 10 years, the patient suffered from really severe impairment of quality of life. And these symptoms are the kind of things that people go to their primary physicians quite frequently. Weakness, lethargy, abdominal pain, joint pains, loss of libido, and so on. And these add to significant impairment of quality of life, and yet these patients were not diagnosed in a timely fashion. Now, of course, with the availability of gene testing for Caucasian patients, the diagnosis is made much more promptly because iron panel screening is part of the routine medical checkup. But I think in your population, this will still remain a problem because the genes that are being checked for are Caucasian genes, and they don't apply to the Indian population. So the burden of disease is really quite severe, and the manifestations can occur quite silently while patients are complaining of non-specific symptoms of fatigue, loss of libido, and so on. This is the biochemical phenotype of hemochromatosis. And so as you can see, the normal serum iron levels are depicted here. In hemochromatosis, serum iron is markedly increased. Normally, serum iron is bound to transferrin. And when serum iron rises to this level, transferrin binding sites are saturated. And so there's a lot of free iron circulating, and this is what causes cellular injury or multisystemic organ involvement. Using total iron binding capacity, you can then determine transferrin saturation, which is invariably elevated in most forms of hereditary hemochromatosis, except one rare variant called the ferroportin disease. And a simple way to think about transferrin saturation is that normally, out of the two binding sites on transferrin, statistically one site is occupied. And so as iron overload progresses, all of the binding sites are occupied. And so then you move from transferrin saturation to 90% and over, and there's a lot of free iron that is circulating around. Of course, the gold standard is a liver biopsy, but serum ferritin is increased, and usually serum ferritin greater than 1,000 is predictive of significant fibrosis, and that would be an important trigger if you are considering liver biopsy. Liver biopsy, one can determine the amount of iron by atomic absorption spectrophotometry and express it as dry weight, and one can then calculate the hepatic iron index to account for age difference in iron in the liver tissue. So hereditary hemochromatosis that you read about in the textbook, by and large, is the one that's associated with chromosome 6. It's an autosomal recessive disease, and therefore both parents have to be carriers, but this 1 in 10 individual of Caucasian ethnicity is a carrier of hemochromatosis. It is not unusual to come across one or even both parents having hemochromatosis. When I trained in England, I looked after an Irish family where both parents had hemochromatosis, and their 8 children, every one of them had hemochromatosis. So this kind of Mendelian iron overload has to be distinguished from secondary iron overload depicted here due to blood transfusion for, say, myelodysplastic syndrome, ineffective erythropoiesis, and there is this African hemochromatosis that was attributed to people in South Africa drinking alcoholic beverages fermented in iron pots. It turns out that there is a genetic factor that predisposes them to iron overload on top of the excess dietary iron accumulation. So the classification of iron overload syndromes have become very, very complicated. We only used to think about chromosome 6 and think that this was one disorder. And I think as we move forward in the era of genomics, some of the disorders that Dr. Sybil mentioned, we are going to find genetic heterogeneity. That means that there are many genes which, if mutated, give you the same phenotype. And here, thinking about iron overload, in fact, you can get iron overload due to mutations in the HFE gene, and these are the various mutations that lead to the clinical phenotype. But there are other genes, hemojuvelin, transferrin receptor 2, ferroportin, hepcidin, and even the African iron overload. All of these, when mutated, lead to iron overload. Of course, in your evaluation of a patient with elevated ferritin and transferrin saturation, please keep in mind secondary causes, such as the iron-loading anemias listed here, as well as parenteral iron overload. Particularly, you will encounter it in the hematology service. But other chronic liver diseases, porphyria cutanea tarda is an important one to recognize, because if you do phlebotomy in these patients, they get better just by iron depletion. And European experience have shown that porphyria cutanea tarda expression is determined by hemochromatosis gene mutations. Hepatitis C is important. Of course, alcohol, fatty liver disease. There is an interesting connection between hyperferritinemia and non-alcoholic fatty liver disease. And this is the one that I find very intriguing as well. In patients who have had portal-cable shunt, they develop hyperferritinemia and iron overload. And then these are the miscellaneous ones. Dr. Yacha covered neonatal iron overload. But keep in mind aceruloplasminemia. Ceruloplasmin is a ferrooxidase. When there is a genetic absence of ceruloplasmin, iron gets trapped in cells of the body, and so you get iron overload, even though the gene that's mutated is ceruloplasmin. I think to understand the pathophysiology of hemochromatosis, it is important to think about the normal daily iron intake. In our daily diet, generally a non-vegetarian diet would contain 10 to 20 milligrams of iron in food, and the bioavailability is very low, so that only about 1 to 2 milligrams of that is absorbed. And this balances what is lost from the body in the form of gut skin, urine. And in women, they are in chronic negative iron balance because of menstrual blood loss. So once iron gets in the body, it is very hard to get rid of it. And the defect in hemochromatosis is extremely subtle, so that absorption of iron increases from normal 1 to 2 milligrams per day to 2 to 4 milligrams per day. And that chronic hyperabsorption of iron, with the intestinal mucosa constantly thinking that the body is deficient in iron, leads to accumulation of iron in the liver and then spills over into the extrahepatic organs. This is a very, very nice review. I recommend all of our postgraduates read this. I've read it several times, and each time I get different insights. And so the iron comes in through diet, 1 to 2 milligrams per day. But you know, that hides a hub of activity that's going on in blood circulation, because the macrophages are turning over red cells continuously, and they are pouring out a lot of iron. And in fact, it produces the reticular endothelial system generates 20 milligrams per day of free iron. That adds to this very small amount from diet. And this is your circulating plasma iron pool, which is utilized for bone erythropoiesis, and then to balance that little amount of iron that is removed from the body. In hemochromatosis, absorption of iron goes in, but importantly, keep in mind that the release of iron from reticular endothelial system has also commensurately gone up, expanding the plasma iron pool. That is why when we look at liver biopsy, we see iron loading in hepatocytes, particularly in the early stages, and the macrophages are devoid of iron accumulation, because the macrophage is behaving very much like the enterocyte. It's putting iron out rather than sequestering it inside. So total body iron under normal circumstances is about 4 grams. Half of it is in red cells. About a quarter is in storage forms such as ferritin, and the rest is in other hemoproteins such as cytochromes and so on. Intracellular storage form of iron is ferritin, which has the capacity to store thousands of atoms of iron. And transferrin is a molecule that transports iron, and there are 2 binding sites. And we talked about how we can understand transferrin saturation in the context of these 2 binding sites. Now, under normal circumstances, the enterocyte is the one that senses how much iron is required in the body. But the field of hemochromatosis has become extremely complicated, and I think it is very relevant to the kind of patients that you see in your practices here. It turns out that the hemochromatosis gene that codes for this protein, HFE, requires several other proteins: hemojuvelin, transferrin receptor, hepcidin, and these actually work in concert to produce hepcidin. Hepcidin is a hormone. It's a 25 polypeptide protein, amino acid protein, that then goes to the enterocyte and interacts with another iron sensor, ferroportin, and then signals the enterocyte to absorb iron from diet. The ferroportin is also present in the macrophages, linking the enterocyte with the macrophage. So when there is a mutation in HFE, then the amount of hepcidin production by the liver goes down and the absorption of iron goes up. This means that the genetic defect in hemochromatosis is in the liver, and if you did a liver transplant in hemochromatosis, you cure the defect. And this was a topic of controversy for a long time, because people used to believe that the defect in hemochromatosis is the gastrointestinal tract and the enterocyte. Now, what about these other iron homeostasis proteins? When you have transferrin receptor 2 mutation, it leads to mild iron overload, because it results in mild decrease in hepcidin, and it associated with mildly increased intake of iron from the enterocyte. However, hemojuvelin, it leads to massive iron overload because it powerfully abrogates the production of hepcidin. And these are the kind of younger patients that you're likely to encounter in your practice. And then ferroportin disease. Here is a situation where there is excessive amounts of iron and virtually no hepcidin production. And ferroportin, shown here, leads to excess accumulation of iron in the reticular endothelial system, which can be confusing for a secondary iron overload syndrome. Again, I took this picture from Dr. Pietrangelo's review in New England Journal of Medicine. I strongly recommend that our postgraduates read that. So this is a schematic depiction of the hemochromatosis protein. It is very similar to HLA-like molecule, illustrating the close connection between iron transport and the immune system, and it binds with beta-2 macroglobulin. These are the mutations, but you know, this is not relevant to your practice in Mumbai or New Delhi, wherever you come from, because the mutation in HFE arose in the Celtic population in Brittany. And these people in 800 AD migrated all over the world and spread their genes, so that in the United States, in Boston, 1 in 143 person is somebody who suffers from the genetic disease hemochromatosis, although its expression is low, clinical expression. What about India? You don't get this kind of hemochromatosis in the Asians and the Indian population. And this was shown in this study by Bruce Bacon and others, where they looked at HFE mutations and found that in the Indian subcontinent, the HFE C282Y mutation is extremely low in frequency compared to United Kingdom, United States, and Australia. And so the field of hemochromatosis has become very complicated due to all these genes that, when they are mutated, lead to development of severe iron overload, some in the younger children as well as younger adults, and with prominent involvement of cardiomyopathy. The natural history evolves initially with biochemical phenotype, tissue injury, and then eventually cirrhosis, organ failure, and hepatocellular carcinoma. Phenotype is modified by these other modifying factors. This is a bad disease. Risk of hepatocellular carcinoma is increased 119-fold, cirrhosis 10-fold, cardiomyopathy 306-fold, diabetes 10-fold, and there is increased risk of HCC in a non-cirrhotic liver. And so I spent a little bit of time last night thinking about what would be the algorithm to give you, the postgraduates, for use in your clinic. So you suspect hemochromatosis. There may be a family history. You do iron studies, and the transferrin saturation is elevated, and then you repeat that. And if the ferritin is greater than 1,000, if the transaminases are elevated, and if there are extrahepatic manifestations of iron overload, together with positive family history, I would strongly recommend a liver biopsy and hepatic iron index, and then do phlebotomy. But if the results are equivocal, you can do therapeutic phlebotomy. And if I have a minute, I will just explain that to you. So here is the different patterns of ferritin and transferrin. Sometimes the very confusing picture can be obtained because of presence of chronic disease and ferritin acting as an acute phase reactant. Hepatic iron index, although we don't use it in the United States now, but I think in your practices, this liver iron content divided by the age in years is going to be an important discriminator between genetic inherited forms of iron overload and the other non-genetic forms of iron overload. So you don't need gene therapy for hemochromatosis. It's good old-fashioned phlebotomy. It's only 1 unit of blood. You remove 250 milligrams of iron. And once iron stores are depleted, maintenance phlebotomy every 2 to 3 months. All clinical manifestations are preventable. Cardiomyopathy can be reversed. Glucose intolerance improves. Hepatomegaly reverses. But arthropathy can be disabling, and it does not reverse with phlebotomy. Prognosis is markedly improved after phlebotomy, as shown here. And one very important practical point is when you do phlebotomy, don't do phlebotomy just checking the ferritin, because that's going to come down very, very quickly. Transferrin saturation will remain high. During this time, the patient is severely iron overloaded. Your therapeutic goals are to normalize ferritin and also normalize transferrin saturation. So your criteria for therapeutic goals have to be very stringent. Otherwise, you're going to end up with a patient who goes on to develop hepatocellular carcinoma, even though you've done phlebotomy. And in my final slide, you will come across patients who don't fit a clear-cut diagnosis and you don't want to do a liver biopsy. Do a quantitative phlebotomy as a diagnostic test. So in that sense, 500 ml of blood removes 200 to 250 milligrams of elemental iron. Normal men have approximately 1 gram of iron stores, and therefore after 4 or 5 phlebotomies during 4 to 8 weeks, these individuals will become anemic. In contrast, somebody with significant iron overloading would usually have at least 5 grams of mobilizable ions, often 20 grams of iron stores, requiring many units of phlebotomy before they become anemic. And so I was going to talk about neonatal hemochromatosis, but Dr. Yacha did a fantastic job at it, so I'll stop my presentation here. Thank you.
Audience.